So let's get straight on into it. So a very important day, as you've heard there. I do have an overview, and there's quite a lot to get through. When I put this topic together, I wasn't actually thinking about what I was going to talk about. I just put the topic together, and then I started thinking about all the things I could talk to you about the topic, and we could be here all night, maybe into tomorrow. So lucky for you, you won't be. But we're going to talk about the significance of World Diabetes Day very quickly. You've heard about that already. We're going to talk about insulin, which was an amazing discovery, and again highlighted on this day, the birthday of the discoverer of insulin. We're going to talk about glucose monitoring, the bane of everyone's lives, diabetes technology, the digital age. We're going to talk about a non-insulin treatment for type 1 diabetes, talk a little bit about surgery, and then some future directions if we have time. So let's get cracking. So you've already heard about what the significance of the 14th of November World Diabetes Day is, so I'm not going to pick on someone in the audience and ask you. I didn't bring any prizes either. So it is an official United Nations Day, and it has been so since 2007. It heralds a global awareness campaign aimed at keeping diabetes firmly in the public spotlight. The theme for this year, as you've heard, is family and diabetes. Now, this message was driven home to me pretty hard just last week. One of my young patients with diabetes was in the hospital having a pump upgrade. They were 23 years of age. Mum was with them. Mum had been looking after diabetes since age 18 months. And so she had nursed this young lad through his whole life, administering insulin, giving, doing the BGLs, getting him to his appointments, and now he was a young adult. And that was a really emotional time for her, sort of letting go of her son and the diabetes. But your mums are always going to be your mums. My mum worries about me. If she didn't want to be involved, I would have to worry. So this theme, I think, is really relevant. So here's this handsome fellow, Frederick Banting, a lot more hair than me. Born on the 14th of November 1891, I did learn something putting this presentation together. Not only was he a medical scientist, a physician, he was a painter. And there's one of his pieces of art there, which you can tell straight away looking at the art that he lives in Canada. He was the co-discoverer of insulin along with Charles Best in 1922. And here's an article that appeared in the newspaper at the time, and you can see there it's titled "Toronto Doctors on Track of Diabetes Cure." So they were even talking about diabetes cure back in 1922. We've come a long way since then, and I'm going to take you through that journey today. It's always interesting looking at these old papers, the types of other things were happening at the time there. So you can see there's an article there about civil war, reserves of coal being high in the city and prices going down. Of course, we're trying to stop using coal at the moment. So in 1922, type 1 diabetes turned from an acutely fatal disease to a chronic disease. That's not that long ago. It's not 100 years ago. If you were diagnosed with type 1 diabetes before 1922, you died. And you died very quickly. Awful disease. Then this amazing discovery of insulin occurred. And they tested it on one person and they responded, and then they took it immediately into the hospitals which were full of young children with this disease and started treating them with insulin, and it was a new lease of life. So here's a couple of examples of pictures of people before they received insulin and after they received insulin. Teddy Ryder, he's a bit of a celebrity. He's one of the first people treated with insulin, and he is also the first person to receive 70 years of insulin. And here's a picture of him before and after treatment. And you can see here he wrote a letter to Dr. Banting. I'll read it out to you. It says, "I wish you could come and see me. I'm a fat boy now and I feel fine. I can climb a tree. Margaret would like to see you. Lots of love from Teddy Ryder." So I do have a quiz question. Anyone can yell out the answer. Again, no prizes. What was the name of Banting and Best's dog? Was it A, Marjorie, B, Wags, C, Odie, D, Clifford, or E, Spot? Yes? Clifford. No, it's not Clifford. Marjorie. It was Marjorie. Okay, so you can see Banting and Best there with their dog Marjorie. So, type 1 diabetes. It accounts for somewhere between 5 to 10% of all diabetes. Its incidence and prevalence is increasing, and we don't quite know why. In Australia at the moment, there's over 120,000 people living with type 1 diabetes who are registered on the NDSS. And if we look in South Australia, it's 8,840 as of the latest figures. There's 9 people diagnosed in Australia every day and who are placed on the NDSS register. And you can see from the graph here, the spread of age of this condition is right from when you're an infant right through to in your 90s. And we do see type 1 diabetes for the first time in pensioners. So it's not a disease of childhood completely, it can affect anyone. So since Banting and Best's time, we now have a much better understanding of the causes of type 1 diabetes, and that's going to help us develop new treatments and ultimately beat this disease. We know that it's the immune system attacking the beta cells in a genetically susceptible person for most people with type 1 diabetes. There is another type called type 1b, which often runs in families. These patients don't have antibodies and they don't have the same gene abnormalities that are present in the type 1a group. We're now better at predicting future risk of developing type 1 diabetes, and this may lead to the way for future screening of at-risk individuals, and then lead the way for future interventions to try and prevent the development of type 1 diabetes. I've got a little graph on the left of the page here. It's a common question I see in the people who come to my clinics. What are the chances, especially when they're thinking about starting a family, what are the chances of my kids having type 1 diabetes like I do? And you can see here it is influenced by whether your mum or dad is affected, but if mum's affected, there's about a 2 to 4% risk that your kids will be affected. Another way of looking at that, though, is it's 96 to 98% chance that they won't. So the odds are still pretty good. But if your father's affected, it's actually a bit more common than if your mother's affected. And if you're an identical twin, it doesn't mean that you're going to definitely get the condition. It's about a 50% chance. So this is my favourite organ of the body. You don't need to tell me what it is. It has 2 important roles. One is producing digestive enzymes, which help digest the food that we eat. And of course, the other is making these amazing hormones. So again, another quiz question for you. So insulin is produced by cells within the pancreatic islet, and this is a picture of an islet with the different types of cells demonstrated in different colours. But with regards to pancreatic islets, the human pancreas contains 1 million islets. 70% of islet cells are insulin-producing cells. Alpha cells located within the islets produce a hormone called glucagon, which of course is the antidote for a hypo. Pancreatic islet cell mass is 2 grams. So what that means is if we took all of these cells out of the pancreas, popped them on a petri dish and actually weighed them, it would be 2 grams in weight. Not very much at all. Or all of the above. What do you think? It's all of the above. So 2 grams of tissue is responsible for regulating sugar in our bodies. That never ceases to amaze me. And I guess it also reminds us why this condition can develop, because it's such a fragile piece of us. There's 2 grams of tissue that if it becomes under attack, glucose homeostasis might all be thrown out of whack. So what does insulin do? It's got all of these important functions. I'm not going to go through them with you, except to say that they can be divided into basically anabolic effects and anti-catabolic effects. They're words that we use when we work in the medical field to prove that we went to university. But we can sum it up much easier and say that insulin lowers blood glucose, it lowers blood fat and promotes fat storage, and that's important for future energy use. And it also promotes protein storage. So that's muscles and other important things that protein do in our body. This, of course, is a picture of me before I went into university. I had hair back then, and I used to be very fit, but I don't look like that now. So let's look at insulin, this revolution in the treatment of type 1 diabetes. Discovered in 1922 and immediately went out to the wards to save people. The initial insulins were actually prepared from animal pancreas. So the companies that manufactured or marketed insulin used to stockpile animal pancreas from abattoirs and things and extract the insulin, and they used that to treat humans who required insulin. And then in 1977, we started seeing recombinant DNA technology. And in 1983, the first biosynthetic human insulin is introduced into clinical practice. More recently, in 2000, we've taken the human insulin molecule in the laboratory, we've modified it, and we've developed what we call insulin analogues. And the insulin analogues are better at mimicking what insulin should do. So that's the timeline. We have different types of insulin. So for the first 50 years of insulin treatment, there was really only one type of insulin. That was the insulin taken out of the pancreas of animals, and it was injected into humans. There was no special profiles. It's sort of a bit of luck of the draw, hit and miss type stuff. Now we have insulins which have different profiles, and we can select insulin with a different profile for a different purpose. So if we want to mimic the background insulin that our body produces when we're not eating, we use one of these longer-acting flat insulins. Or if we want to mimic the insulin production that should occur after a meal, we might use a rapid-acting insulin. And this is just an example of the different profiles we prescribe. So we can compare insulin analogues with human insulin. So insulin analogues, as I said, were the human insulin molecules which we've now modified in the laboratory. If we compare the two, you see less hypos with the insulin analogues versus human insulin, less weight gain, and improved HbA1c. So the long and the short of it, as you'll see in the next slide, is that most of our patients should be managed with an insulin analogue of one form or the other, as opposed to the human insulins. We now have some longer-acting basal insulins, and some of you would be familiar with a brand called Toujeo, which is also an insulin analogue, but it's a concentrated form of glargine, which is the active ingredient in Lantus. In 2019, just recently, this has sort of slipped under our noses, we now have what we call biosimilar insulins. Insulin glargine. So insulin glargine is the ingredient that's in Lantus. So what these companies do when they develop the insulin is they have to take it through the laboratories, prove that it works, and then they start testing it on models, and then they start introducing it into humans, and they have to go through a robust scientific process to prove that A, it works, and B, that it's safe. And if they get a success, they can then patent it and market it. So that explains some of the delays that we see in some of these treatments. They put a patent on it, and then that patent eventually wears off, and other people can manufacture that. Now, insulin's a very, very clever molecule. You have to get it exactly right. So I think I would urge caution with people using biosimilars who are already using the original Lantus brand. So when your chemist says, is it all right for you to do a brand substitution here, as some of them are starting to do with these biosimilar insulins, if you're already on Lantus, I would discourage you from selecting a biosimilar. That's my opinion, and that's supported by Diabetes Australia as well. It's different if you're starting insulin for the first time and you're going to plan to stick with that brand. Sure. So my quick analogy here is this is straight out of Maggie Beer's cookbook. This is her chocolate cake following her recipe. I got all the same ingredients, followed the instructions, and that's what I came up with. Probably tasted as good, but didn't get the presentation or get me through to the next round of Australian Bake Off. So the standards of care when it comes to insulin recommend that people with type 1 diabetes should be treated with insulin analogues, as you've already heard me mention, because it has a lower risk of hypo compared to the older insulins, but also should be treated with multiple daily injections of a mealtime insulin with a background basal, or alternatively using insulin pump therapy. That's what the standards of care support. The standards of care also say that we should empower people with diabetes to adjust their mealtime insulin doses according to how many carbs they're having, what their sugar is when they're about to eat, and planned activity. So it's very different to the way we used to do things 10, 15, 20 years ago. So some of you remember the talk about exchanges. You went to your doctor and your doctor said, this is how much insulin you're going to take. It's a set dose for breakfast, lunch and tea, and you have to have 3 exchanges with this meal, 3 exchanges with that meal to match the insulin. We know that that's the wrong way to do things. What we should be doing is through intensive education, and it involves a multidisciplinary team, so a diabetes educator, a dietitian and an endocrinologist, is empowering you to adjust those insulin doses based on what your sugar is when you're about to eat, what you're about to eat, and what you're planning on doing after. It is hard work for anyone living with diabetes to do the carb counting. And another quiz I give my team every year at the hospital is I put a meal on the board and I ask them all to tell me how many carbs are in there and then to tell me their answers, and you get a real range on what the actual carbs are. So this means teaching people about insulin carbohydrate ratios and insulin sensitivity factors. An insulin sensitivity factor is a description of how much 1 unit of rapid-acting insulin will lower your BSL. So let's move on to insulin delivery. So I'm taking you through a journey over the last 100 years or so about what's happened in type 1 diabetes. So these are some insulin delivery devices, and the one on the right here was actually gifted to me by someone who comes and sees me regularly. Has anyone recognised this? No? It's almost that big, by the way. It's huge. And it looks like a big gun, and it is a big gun. It's actually invented here in South Australia by this popular Mr. D.T. Lewis of Port Lincoln. I hope there's no relatives in the audience. What one would do is draw up their insulin in the syringe. They would put it in the gun. They'd hold the gun to their leg and pull the trigger. And this was how insulin was delivered. It was said to be painless. I mean, here's an example of a glass syringe that one of my patients came and gifted me as well. They used to use that when they were much younger. So then we started seeing syringes like this, calibrated. Again, many of you would be familiar with these. Have you seen them before? Yep. We still use them in hospitals today, and we use them to draw up insulin to put in pumps and that sort of thing. And before the advent of pens, we used to all administer insulin using vials, and we would draw up clear and cloudy insulin. Remember the clear and cloudy insulins? And you'd have to get them in the right order to make them work. If you did it in the wrong order, you'd turn your clear cloudy and so on. So we've come a long way. So in 1986, we started seeing the first pens. And this list isn't exhaustive, so there's some there that you'll recognise and some that aren't included. But we now have durable devices where you put a little glass cartridge in, or disposable devices. I'm a bit of a greenie, so I like asking companies what they're doing about their carbon footprint when they come and show me these devices. But I don't tell all the people who come to see me they have to use a durable device, so I tell them to plant a tree. So another quiz question. Does anyone know where the term diabetes mellitus comes from? Sorry? Greek. It's partly Greek, yes. Okay, so we'll move on here. So diabetes comes from a Greek word to mean siphon. Siphon, make lots of urine. So again, going back in the ages, people with diabetes used to drink a lot and piddle a lot. And so the early physicians of the day recognised that they had this condition and they wanted to give it a name, and the obvious name was diabetes, siphon, to make lots of water and to drink lots of water. In 4000 BC, an Indian physician noticed the sweet taste of urine. Now, what the hell was he doing tasting urine? But anyway, medical students became really handy from that day on when they were doing ward rounds with you. And in 1674, Thomas Willis, the personal physician to King Charles II, coined the term diabetes mellitus, with mellitus meaning Latin for honey, so sweet urine. So insulin was discovered in 1922. For the first 3 years, people were administered insulin. We had no way of actually checking sugar levels. So home testing of urine was introduced in about 1925. And again, some of my patients have been living with diabetes for more than 60 years, and they remember this kind of thing happening in their home when they were little, their mother heating up their urine. So what one had to do was to take 8 drops of urine and mix it in a test tube with 6 mils of Benedict solution, and then you would boil that water for 5 minutes, and you'd look at the colour change, and depending on what colour it turned, you knew how much sugar you had in your urine, and therefore it was a bit of a surrogate of what you had in your blood. Pretty crude, pretty archaic. In the late 1940s, the first urine sort of dipstick appeared that could be used at home. So by the 1960s, that was fairly routine for people to do dipstick tests on their urine to see whether there was sugar there or there was no sugar there. And then in 1964, available for doctors, the first strips for testing blood glucose became available. And what one had to do was put a drop of blood on this special piece of paper for a minute and then wash the blood off and look at the colour change and compare it to a chart. In the 1970s, the first blood glucose monitor appeared, and again, it wasn't a take-home device. It cost $500, so anyone who was around in 1970 knows that could buy a house back then. And it was designed for being used in the doctor's surgery. In 1976, HbA1c testing appeared. That wasn't that long ago, 1976. And in 1983, Accu-Check developed a glucometer which could be used at home and in clinics, called the Reflolux or something like that. I remember seeing this glucometer in the clinics at the Queen Elizabeth Hospital when I was a registrar. And we had a patient come into our clinics. We used to have to go and ask our boss to get permission to do a BGL, and we were sort of escorted to a special room which had about 3 locks on. If they had retinal code technology at the time, we would have had to put our retina against it, and the door would open, and then we would do a BGL, and the appointment would almost be over by the time you actually got the results. So we've come a long way. We're not going to talk about the history of lancets. So here's an example of some modern glucometers. Many of you will recognise these. These come and they go. I met the rep this morning from Accu-Check, and just as a heads up, whoops, pointing on the wrong screen, I quite like the Accu-Check Aviva Expert. It doesn't check ketones, but it does include a carb counting facility. That one stopped being made. So if you really like that meter and you're using it, get one now, or maybe get 5. The The strips will be available for years to come, but the actual meter is disappearing. The long and the short of it is that people with type 1 diabetes ideally should have a meter that can also test ketones. And just by way of interest, a normal ketone level is less than 0.6. Really sick is 3 or above. Between 0.6 and 3 is you might be getting sick. Keep a close eye on your sugars. Take some extra insulin. Contact your health professional. So in 1993, this is where you're welcome to switch off if you like, because I'm going to talk about a study. This was a really a landmark study called the Diabetes Control and Complications Trial. People were recruited to this from 1982 and it continued through to 1993. And it was designed to see whether putting one group of people with type 1 diabetes on a basal bolus insulin schedule, so 4 injections or more a day, or a pump, compared with the other way of treating type 1 diabetes back then, which was like using a twice-a-day injection of a pre-mixed insulin. And these patients were followed up over 6.5 years to see whether there was any difference in the outcomes of treating one group intensively versus the other group more conservatively, which back in 1982 was the way to do things. At the end of the study, there was a difference in HbA1c between the two groups, 9.1% in the conventional group and 7.2% in the intensive group. When they looked at the results, they demonstrated that the complications rate was much lower in the aggressive treatment group who received the multiple daily injections or pump therapy versus the people who received conventional therapy. So it really changed the way we thought at that time that we should be treating type 1 diabetes, using 2 different types of insulin, giving multiple injections a day, and also doing lots of sugar checks at home. It did come at a cost. It came at a higher rate of hypos, and that wasn't insignificant. So another way of looking at these numbers is that for every 100 patients with type 1 diabetes managed each year with a basal bolus insulin schedule, there were 61 bad hypo events. So it was quite common. And then weight gain. So people who were treated in the intensive group were on average 4 or 5 kilos heavier than the conventional group. Now, it is worth remembering that this study was done with human insulins. It was before the age of analogue insulins. So analogue insulins have allowed us to achieve these sorts of sugar targets with a lower risk of hypo and a lower risk of weight gain. Now, at the end of this study, everyone was pleased with the results. The study finished up, and the people who participated were sent back to their GPs and endocrinologists. And what we saw was that in the conventional treatment group, sugar control improved because everyone switched to the right way of doing things. In the in the intensive group, sugar control deteriorated a little bit. And that's not uncommon. When you're in a study, you're being prodded and you're poked and you're being pestered constantly. And so often your sugar control, when you're actually in the studies, a little bit more tight than perhaps it would be in the real world. It's not easy having good sugar control. Anyone who tells you otherwise doesn't know diabetes. But anyway, they followed these people up for more than 10 years, and you can see there was no difference in their HbA1c at the end of that follow-up period. But what was really interesting was that the risk of complications, developing long-term complications, and now complications such as heart attack and stroke, was still less common in the group that were treated intensively right from the beginning. And so again, that's made us change the way that we think about managing diabetes as well. So I guess there was, in the past, a bit of an attitude by doctors and clinicians that when you're a kid and you've got diabetes, it's not so important to put someone on a 4 injections a day schedule or a pump, and we can just sort of aim for mediocre sugar control, because what's really important is avoiding the hypos at school, getting kids to school and that sort of thing. But now we have the attitude that really intensive control right from the outset in the long term has long-term benefits. So we really promote that aggressive treatment. And I think we sort of underestimated how well our kids actually do with this technology and the basal bolus insulin schedules. We've got to give our kids more credit than we sometimes do. So we're still talking about sugar targets and sugar control. So the dreaded HbA1c, which measures the quantity of sugar control over 3 months. It's an indirect measure of average sugar. It does not measure blood sugar ups and downs. So the highs and the lows, the HbA1c doesn't tell us about that. And there are lots of things that can influence the accuracy of HbA1c. So if you've got anemia, or your kidneys don't work 100%, or you're having lots of hypos, or you've had a blood transfusion, or you go to the blood bank and you donate blood regularly, they all influence HbA1c. But nevertheless, doctors like banging on about it, and we do that because the DCCT said that if we could get your HbA1c to 7% and keep it there, you're going to do well. Our target overall is 7%. What about BGL monitoring? So BGL monitoring, this is the capillary checks that people do at home. Very important for guiding decision making, both for clinicians, but also people with diabetes. It facilitates self-management. So if we're going to be adjusting our dose from one meal to the next, we need to measure to actually know how much insulin to give. And of course, for monitoring for the dreaded hypos. So again, this table on the right sort of summarises our ideal targets. Now, in our diabetes utopia, we would love to see a sugar of 6, 6, 6, 6, 6 from one check to the next, but we know in reality that does not happen. If you eat the same thing, do the same thing, take the same insulin dose, what happens? Your sugars vary from one day to the next. So it's very, very frustrating. But we sort of look for patterns and trends, and what we're aiming for in the non-pregnant cohort is before meals, ideally a sugar of less than 7.2, and 2 hours after a meal, less than 10. How often should I check my sugar? What do the guidelines say? Now, I don't want to freak anyone out by this next lot of information. So if you think you're going to freak, just look at SpongeBob. SpongeBob makes everyone relax. But the guidelines say intensive insulin schedules, you should be checking up to 10 times a day. That is ridiculous. I don't have diabetes. I've pretended to have diabetes for a week, and I checked my sugar 4 times a day for a week. I was over it after the first day, and by the 5th day, the weekend was rolling around, and I didn't even need to make any decisions about diabetes, didn't need to give myself insulin or worry about hypos and all of those things. So don't let your doctor or your clinician beat you up about how often you're doing your sugars, because it hurts and it's hard work. But nevertheless, it's an important part in decision making and getting where we need to get to. But the guidelines say if we're going to use this information to adjust our insulin dose, we should be doing a check before we eat. We should occasionally check after meals to see whether we actually gave the right amount of insulin. Prior to bed's always handy. We want to make sure we don't go low overnight. Prior to exercise, prior to critical tasks such as driving, and then if you're suspicious you're going low. So I like books. I'm old-fashioned, but I'm sort of coming around when it comes to technology. I have a big cupboard full of books because you can't get the books anymore. And I do ask some of the people who come to see me who also like books to keep a record for about a week before they come to see me. And one of those books can last a very long time when you're only actually writing them down for a week. But I like seeing that 1 week of sugar measurements because it tells me about the quality of sugar control, and I can match that with the HbA1c in terms of making some decisions. Now, this is a game breaker. Continuous glucose monitoring. And our government really needs to get off its bum and start supporting us more about using this technology. These systems first appeared in 2000 They measure interstitial glucose, so they're not measuring blood sugar, they're measuring interstitial glucose every 1 to 5 minutes. And they provide us with an abundance of data for analysis. It is worth mentioning that there's a bit of a lag between interstitial sugar and blood sugar, so people who use CGM just need to be aware of that lag. It's been demonstrated to reduce the time in hypos without compromising your HbA1c, and in fact has been demonstrated to improve HbA1c and also improve time in your target range. And this is an example of what it looks like. You've got your transmitter with a little sensor, with a little Teflon cannula that pokes through your skin, measures the blood sugar, which is measures the interstitial sugar, which is diffusing from the blood. There are two types of these devices, broadly speaking. There's the real-time CGM, and two big companies on the market are Medtronic and Dexcom, of course, and you're able to see your sugars in real time with this technology. You're allowed to set alarms on your mobile phone or on your mum's mobile phone, telling you when you're high, when you're low, rate of change, that sort of thing. The other technology is this iCGM, and that's flash glucose monitoring, where you wear the little sensor on your arm and you have your reader or mobile phone and you hold it there and it tells you what your sugar is now. Those sensors, of course, store 8 hours worth of information. So if you read more than every 8 hours, you're going to get continuous information about what your sugar's doing, and that's really useful for helping make decisions. Those pictures were just pictures of the technology. So as I said, the Australian government has subsidised some groups of people with diabetes type 1, and they have some aims of their program, and this is administered through the NDSS. And I guess we shouldn't take it out on the NDSS, our frustrations that this falls short of who should be getting the technology. But the government's aims were to reduce the number of severe hypos, improve sugar control in people who have difficulty picking up when they're going low, so we call that hypoglycemia unawareness, reduce the number of visits to the emergency departments, days off work, days off school, and reducing the anxiety of people living with diabetes or people who live with people who live with diabetes. So who's eligible? Children, of course, up to age 21. And I'm an adult physician, and so I do have lots of young adults coming to see me. And unfortunately, at the moment, for their 22nd birthday, this technology is taken away from them. Very disappointing. There are some adult groups who can now access it, and that's as of this year. So if you're a lady with type 1 diabetes who's planning a pregnancy or who is pregnant, you will get subsidisation. But after baby arrives, that'll be taken away again. And then if you're over the age of 21, you have a concessional card or you're a pensioner, you can't pick up when you're going low, so you don't get any warning symptoms, and you've presented to the emergency department or required an ambulance because you've had a severe hypo, the government will consider subsidising there. So it's quite restrictive, as you can see. So this is our Prime Minister. What Santa brought him for Christmas wasn't CGM, it was a piece of coal. I encourage you to make an appointment with your local member and go and have a conversation with them and do it repeatedly. Check your sugar while you're in there as well. Let them know what it's like to live with diabetes. Now, this is a recent announcement by the government. If you are unfortunate to have a disability and to be a client of the NDIS, there is a possibility of accessing this CGM technology through an application through the NDIS, and that requires a letter of support from your healthcare worker. So this technology allows us to put together something called an ambulatory glucose profile. So this is from midnight through to midnight, and we get these continuous curves. And it's a retrospective analysis report of CGM data. A lot more information in here, and we can use this to adjust insulin doses, but also on a day-to-day basis to use it to make decisions about behaviour, what you're about to eat, what activity you're doing, and so on. So I think in the future we'll be talking not about HbA1c when everyone's using this. We're going to be talking about terms like time in range, time in hypo range, that sort of thing. And that will actually correlate better with day-to-day and long-term risk. So you'll hear some of us starting to use that terminology already. And so here's an example of one of my patients who was using the Libre, and we can see an average sugar of 8.5 here. It's estimated the HbA1c is 7%. We can sort of get a picture of what time of the day the sugars are higher. But down here is the low events, and you can see all these low events between midnight and 6 a.m. That's what the red is there. And people sleep through this. They don't know they're having it. And that tells me straight away that there's a problem with the long-acting insulin here. So moving on to pump therapy. The first pumps appeared in 1960. Here it is. I ride a bike, and this wouldn't go very well on my back while riding my bike. But they're designed to deliver insulin continuously via the subcutaneous route, mimicking normal insulin secretion. It only uses rapid-acting insulin, and we program into the pump these insulin carb ratios, the insulin sensitivity factor, insulin duration of action, and blood sugar targets. And they're a lot of hard work, but they're worth it in the long run. Again, they're very expensive, and our government doesn't help us out there. So there are some pros and cons. They better mimic physiology. Fewer injections, so 1 needle in your tummy every 3 days compared with 4 or 5 a day. Fewer injections, lower insulin requirements, greater flexibility. Consumers are generally happier, and it can be paired up with CGM. There are some cons. One of these devices costs $9,500. You can get infections at the insertion sites. If the needle does dislodge, you're at risk of ketoacidosis. But fortunately for most people, they don't have too many problems with needle dislodgement. So again, here's some examples of pumps. Anyone using pumps here or know of anyone using pumps? So you're seeing them more and more commonly. Lots of clinicians don't know about pumps. So when I'm starting someone on a pump, I say there's only 2 people who are allowed to touch this pump, you and me. Anyone else wants to touch it? Unless they get our permission, because they might do silly things with it. So here's some examples of some of the pumps that are available in Australia. So we now have this really nifty technology, again expensive technology, where we can combine insulin pump use with the continuous glucose monitoring. And if our continuous glucose monitoring speaks to our pump, it can switch the pump off when it detects you going low. We call that sensor-augmented therapy. And the studies that have been done demonstrate it has a huge impact on reducing risk of nighttime lows, improving HbA1cs, reducing requirement for going to hospital, reducing ketoacidosis, reducing time off work, reducing fear of hypos, improving quality of life. So the evidence is there. This year, at the beginning of this year, a new type of pump was released in Australia called the hybrid closed-loop sensor-augmented insulin pump therapy, and this has taken it to the next step, where there's an algorithm in the pump, and it interprets the continuous glucose monitoring information, and it will alter your basal rates delivered via the pump for you. And again, the data supports that people spend more time in range and are less likely to have a hypo when using this technology. Now, I'm the first to put my hand up to say that this technology isn't perfect. It will get better. So we're now in the digital age. I can tell you a big story about that. I freaked out when my Nokia phone, my push-button Nokia phone, stopped working a few years ago. When I went into the Telstra shop and they said they don't make those anymore, and I was going to have to use a screen with a screen on the phone, touch button thing. So I walked out without a phone. About 2 days later, I realised I needed a phone, so I reluctantly went back and got my iPhone, and then I found a bike riding app, so all was happy again. So the digital age, pretty amazing. Again, Banting and Best didn't have privy to this. But we have the internet and these programs that help you connect with your clinicians outside of appointments. You can download pumps, download meters, email us, that sort of thing. We also have these apps that I just mentioned, and also networking, and that's really important. You guys networking with each other, or clinicians networking, us all speaking to each other. Amazing. So here's some more facts, no quiz. 92% of Australians use the internet. My parents-in-law aren't in that group. 80% own a smartphone. On average, we check our smartphone up to 30 times a day. Who's checked their phone 30 times a day today? We've got a couple of honest people. Apparently we check it 30 times a day. So internet has increased resources for clinicians and people with diabetes. These are just some of my favourite sites. There's no point sort of jotting them down. Most of them you know anyway, and there are many, many, many to choose from, and my selection is biased on what I need it for. But the apps are pretty cool too. So My Life is an app that you can use for carb counting, Calorie Kings to help you work out all the grams of carbs that are in different items, Strava's to help you track your exercise. I've been told we're getting near the end. So what about a non-insulin treatment for diabetes? So there is a whole lot of medications that have been developed for type 1 diabetes, and they've been tested, and most of the time we've been disappointed. But this class of medications, which appeared in Australia probably 4 or 5 years ago now for type 2 diabetes, has promise in treating type 1 diabetes as well. It doesn't replace insulin, it complements insulin. And the way it works is that every one of us without diabetes filters 180 grams of sugar every day into our urine. But it never finds the toilet because our body reabsorbs that sugar. And it does that in the proximal part of the kidney here. So if we can block the receptors that reabsorb this sugar, and you, instead of reabsorbing this sugar, piddle out this sugar, it's a way of getting rid of calories, getting rid of sugar. And it appears to work in type 1 diabetes. Now, it's not approved for use in Australia. I have been involved in trials where it has been used, and the results have been very promising. It is now licensed in Europe to be used in patients with type 1 diabetes in Europe. So it will come. I do have patients using these treatments today on a private prescription, and the risks have been explained. So we've been to the moon since we've discovered insulin. Donald Trump also wants to take us to Mars. I want him to be on that first ship. So surgical treatment, there are a couple of surgical treatments. The first whole pancreas transplants were actually attempted back in the 1960s, and they continue today. Again, you know, people say, why can't I have a pancreas transplant that will fix all of my problems? It will fix all of my problems, but it comes with other risks of surgery, risks of immunosuppression. So we've got a lot of things to do there. But until end of last year, there were only 2 sites in Australia doing this sort of surgery. And at the end of last year, the Royal Adelaide Hospital became the 3rd site. So that's pretty exciting. What about islets? We can actually take islets out of human pancreas, and we can infuse them into patients with type 1 diabetes. Again, you require immunosuppression, but that can help address some of the problems in diabetes. Now remember, one pancreas has 2 grams of cells. They are very fragile cells. By the time we take them out of a pancreas, prepare them, infuse them back into the recipient, 70% have died. So only 30% get to their final destination of doing their job. And that's why it doesn't cure diabetes in most cases, and that's why it needs to be repeated. But it can lead to other benefits. Now, some of the challenges around islet transplant are being researched. Again, for time, I won't go through that, but this is the way of the future. Oh, my stem cells has shifted. That's meant to be there. So I think we will see stem cells being used to create islets, and having these islets infused back into you. and perhaps not requiring immunosuppression. You hear us talk about there's going to be a cure for diabetes, and there will be a cure for diabetes, but it's not going to be tomorrow. But some of the areas that cure might come from is genome sequencing and altering genes, which are responsible for the development of diabetes. If we can stop the immune attack against those precious beta cells, that might be a way of preventing diabetes in someone who we know is at risk of diabetes. We might be able to do that through a vaccination or immunotherapy. And then, of course, we can keep looking at these beta cells for transplants. There has been a trial recently published looking at this drug called teplizumab. It's infused over 14 days in people at risk of type 1 diabetes. They've got the family history, they've got the positive antibodies, but they haven't actually developed diabetes yet. And then they're followed up, and in this trial, small trial, there was a significant difference between the rate of people who went on to develop type 1 diabetes versus those who got the placebo, so the sham treatment. So this is an example of promising treatment in people we can identify at risk of diabetes. So it may not help people who have it today, but it might help their children. Now, one of the audience members comes and speaks to me about bike riding at all of their appointments, and they wanted to see a picture of me in my Lycra. So here it is. This is me at the top of the Stelvio Pass in Italy. I rode up that hill twice in the day, and at the time it felt like I was never going to get to the top. So I guess I'm trying to motivate you to keep optimistic, and we've got future exciting developments to come. I also want to remind you that you should live your dreams, and nothing's not achievable living with diabetes. So we have some examples here. This is Theresa May. No one would want her job. She didn't want it either, but she's got type 1 diabetes, and you can see she's wearing the Libre there. This is my friend Justin Morris. He's an ex-professional cyclist. He's now a life coach, so he's in a professional cycling team. This is Wasim Akram, amazing fast bowler for Pakistan. So I've finished.